Dave from Brisbane, very jet lagged. So we're going to talk about treating a certain type of dysfunction in AT which affects what's called mitochondria. And mitochondria, everybody's got them in their cells and they're like little energy packets or like little batteries. And we have genetic disorders that I look after as a paediatrician and a geneticist. We have primary genetic disorders in mitochondria that affect things like energy, neurology, multi-system diseases. But we also know that there's other genetic disorders that secondarily affect the way that mitochondria work. And that's been known in AT for quite a while. And within our clinic in Australia, and with the help of Martin Lavin, who I can't see where he is, we've been exploring that a lot further and have found what happens within the AT mitochondria is basically they just kind of implode on themselves. There's a really important cycle in mitochondria called the Krebs citric acid cycle, and it acts like a crank just to turn things up. And it doesn't work in AT, and we think the reason is because calcium doesn't come in. And what happens then, if the mitochondria aren't working, they just cause the whole cell to implode. And the biggest metabolic block is a dead cell. So what we thought, well, look, is there a way that you can basically refuel the mitochondria or hotwire it? And triheptanoin is an oil. It's like, you may have heard of medium chain triglyceride. So if your kids are on certain type of medical formulas through a peg, they will often have these fats put in called medium chain triglycerides. Triheptanoin is a slightly different chemical version of that, and it feeds straight into the TCA cycle that doesn't work. And my specialty in paediatrics is metabolic medicine, so body chemistry, genetics. And we've been using triheptanoin for over 15 years for some of our other disorders that affect mitochondria. So Martin and I then decided we were going to try it in AT, and certainly in AT cells, so either cells that Martin had made via CRISPR in the lab or stem cells that we had generated from AT patients. And then in brain organoids, mini brains, we found that the cell survival was better when we gave them triheptanoin. Which then led us to a clinical trial, which sounds simple, but it took quite a lot to get there. We had about $3.5 million to run it. And we were what we call blinded, so the only people who knew what was going on was the metabolic study dietitian and the dispensing pharmacist. And we divided people into three groups: those that started on the drug and just went up slowly, the ones who had what's called a placebo and then went up, and another group that had placebo for a couple of doses and then went up. And we had 31 people enrolled in the trial. And within Australia, we've got about 50 AT patients that we know of, and there's about 40 that engage with the clinic. So we actually had quite a lot in the group. There were 8 that pulled out, and mostly they were, 2 of them were because they're having side effects from the medication, but the others it was, Australia's really big. It's bigger than Europe, much bigger than Europe, and it's a pain in the arse coming from one side to the other. So being in a trial was hard. We were measuring what's called the primary endpoint was the cell survival in nasal epithelia. So we did like a COVID swab. Martin fiddled around in the lab with growing them and then testing them, and the percent of survival in that was statistically significant, quite significantly. I'm a paediatrician, I don't care what's happening in nasal epithelial cells, I care more about what's happening in the patients. And we did find that there was improvement in the clinical scores that we did, like the ICAR and the SARA scores. And to be fair, we didn't think we'd see a lot in our adult patients, but we did. So the average age of people involved in our study was 16, so most of the, at least half of our population were in wheelchairs, so a bit further on in the disease process, but about half of them were still ambulant and walking around. And when we looked at the trial data, we certainly did see clinical improvements across the spectrum. That was more obvious in the younger kids. They were less ataxic, but even some of the adults had improved gross motor function. which didn't mean they got up out of the wheelchair, but one of the girls, she's 25, has been in a wheelchair for 15 years, and near the end of the trial she was able to push herself up off the toilet. Now, there was no difference in her hand-eye testing, but if you can get off the toilet and you don't need your carer to help, that's pretty good. Yeah. We know that our adult patients have a lot of trouble with choking, and particularly on food, and we found that that was better and statistically significant as well. So there was less choking. What was most improved was some of the fine motor. So even though, again, on the scales, they looked the same and we're doing finger nose, but they had better hand function so they could feed themselves. And if you can sit at the end of your table and have dinner, talk to your family, not be fatigued, and I'll come to that, and not choke on your food, that's actually quite a significant improvement from a functional point of view. Fatigue is something we really don't have a good measure for, but it's such a big thing for the AT families. And that was universally a significant improvement in families. So instead of the kiddie going to school and then just coming home being knackered, they could go to school, engage in what they had to do their therapies in the afternoon, have dinner with the family, engage in discussions, and then go to bed. So that was good. What else? There was some other biochemistry that we'd seen that had improved. The group before had mentioned a thing called neurofilament light chain, and we know that in your body, in your brain, you've got the nerves are divided into two things. There's the actual nerve cell, which is like the receiver on a phone, and then the wiring. And neurofilaments are like little, kind of like bits of wiring, really, around the cord. Now, your body just naturally releases neurofilament from nerve cells into what's called your CSF and then into your bloodstream, and that just happens over your life. But there's been a number of other disorders where it's been quite significantly elevated. And we have seen that it's been elevated in AT previously. We found that in our study, but we also found that it dropped quite markedly when we used our triheptanoin. Interferon signature is a certain type of immune response, and we know in AT there's sometimes quite unusual immune responses. So if you get a virus and then you get a fever, that's your body making things called interleukins and cytokines. And we did see an abnormal number of interleukin type 8, we've seen that before in AT, but it dropped down with treatment, and this other inflammatory pathway, which again dropped with treatment. So we had 24 people that finished the study. In 18 of them, there were very clear improvements, mostly, I think, in the fatigue, but also in speech, being able to be understood, talking louder, talking more often. And that was all lost when we finished the trial. Took us about 11 months then to get the open label access up and running. And in the meantime, we'd seen, again, a statistically significant blip in the neurological scores that started to deteriorate. And over the last 12 months, they've stayed stable, and we've had ongoing biochemical improvement. About 40% of people had side effects, which were diarrhoea and abdominal pain, distension. However, that's dose dependent. So when we actually capped the dose, they went away. Okay? So there does seem to be a bit of a sweet spot in around 20% of your caloric intake in terms of efficacy and tolerability. So what we've then found, again, as a metabolic physician, I'm very used to treating a complex disease with a couple of different things, and this isn't Lord of the Rings. I'm not Gandalf. There's no one treatment that's going to rule them all, I think, for AT. So we had been looking at combining triheptanoin with also nicotinamide, although they work slightly differently, to see if there's a combined effect that improves function there. And when Martin had been playing with our AT cells and combined triheptanoin with nicotinamide, the cell survival was not quite the same as controls, but was a lot better. So we're planning a bigger trial where we'll look at not only the efficacy of C7, but also combined treatment as well. So disease modifiers, I mean, you are going to hear a lot about treatments, even genetic treatments, ASOs. It's important to bear in mind they're not cures, they're just a disease modifier, turning one disease into another. But at the conference we were talking about, you only need a little blip, a little jump in ATM function, just a bit squeaking through to make the cells work better. Looking at it from the other direction, sometimes you only need a little small improvement in your function that makes a big improvement in your quality of life. And that's why we're all here.